excited about that turnout for today. But without further ado, please allow me to introduce you to Dawn Keel. She became a licensed professional counselor in 2008 and a certified professional counselor supervisor in 2013. Dawn received her undergraduate degree from the State University of New York at Geneseo in 1996, and her graduate degree is from Canisius College in 1998. She has worked in the behavioral health field for over 27 years with diverse roles in public, private, and nonprofit sectors. Dawn has worked for DBHDD for 12 years and currently serves as the Director, Office of Crisis Coordination. Previously, she served as the Behavioral Health Regional Services Director for the Region 2 Field Office. Dawn is responsible for enterprise oversight of the DBHDD state-funded crisis system and collaborating with internal and external partners for the implementation of 988. Please welcome me and join Dawn Keel.
Thank you for having me here today. I'm going to take just about 20 minutes this morning and talk to you about 988. Some of the information that Melissa provided will make my presentation a bit faster, so I don't have to go in and talk about all the wonderful work that they're doing. But I will highlight some of the collaborative work that we've done leading up to the implementation and afterwards. So, show of hands before today. How many of y'all have heard of 988? Oh, lots of people. That's great. It's getting more and more well known, which is exciting. 988 rolled out July 16th of 2022. We just recently had a little celebration at cake for a 2-year-old birthday party. I thought it would be appropriate. It was a fun event. And we were able to thank our partners that have been with us all along through this process. But for those that have not heard of 988 before, it is a 24/7, 365, 3-digit number that's available nationally that anyone can call. It's free of charge and it's anonymous. Some of the key features of 988 is that when someone calls there, they're immediately connected to call center staff that are trained to meet their needs, as opposed to going to an emergency room or having to be transferred over from other resources. We believe that this promotes cost efficiency and really reduces the impact on safety resources, like first responders, if we can dispatch our behavioral teams instead of having them go out. And then ultimately, we hope that having 988 in place will help to decrease the stigma of reaching out for care, because behavioral health has come a long, long way in the 27 years that I've been a part of this field, but we still have a long way to go for helping people feel comfortable to reaching out. So as I said, I've been around since maybe some longer than some of y'all have been alive. But this is the biggest thing that's happened in my career. And I'm so honored to be a part of it here in Georgia. It was recognized as a need in the late 2010s at the federal level that we needed a one-stop shop for people that needed help reaching out. And so with broad bipartisan support, in 2020 a federal law was passed that signed 988 into law with implementation in 2022. It was designed to meet the rising needs of mental health and substance use problems, as well as people that need intervention for suicidal thoughts. And that was pre-pandemic. So that need was recognized before the pandemic began. And as y'all might imagine, you might have experienced it yourself, the need for mental health supports vastly increased during that period of time. So it was very timely in that way. So the first part of the law required all telecommunications companies in the United States to have 988 available by July 16th of 2022. The second piece of the law mandated states to have systems in place to meet the needs of people that call 988. So in Georgia, we were very fortunate that we had been building our crisis system over the period of 20 years leading up to the rollout of 988. And so I'm going to talk a little bit about what public services are available in Georgia for people that are experiencing a behavioral health crisis. I will give a caveat that this mainly focuses on public services, but there is an entire private network out there for the higher end services, the Safe Place for Help, which are, private hospitals or inpatient facilities that are available for people. So 988 considers behavioral health services for crisis in three main categories: someone to talk to or someone to call, someone to respond, and a safe place to go for help or crisis care. So in Georgia, we have had a 24/7 hotline in place for 15 or more years. It's the Georgia Crisis and Access Line. And all of our 988 calls in Georgia that have Georgia area codes are routed to the Georgia Crisis and Access Line. We have invested heavily in that service to have more call takers available, those call takers to be able to respond faster, and less calls to roll over to the national call centers. But we also have Peer Run warm lines in Georgia. These warm lines are run by people with lived experience with a mental health condition or a substance use disorder, and they use that lived experience to help others in need. Again, I've been a clinician for a long, long time, but somebody that's walked a mile in that person's shoes can often engage that person better than someone like me, who's been trained in clinical services. So we're very fortunate to have that. One of the questions that came up before this presentation is there an interplay between the peer warm lines and 988, or the Georgia Crisis and Access Line? And the answer is yes. So when someone calls either of our peer warm lines here in Georgia, and they actually need a higher level of crisis intervention, they can be transferred over to 988, and vice versa. If the person calls 988 and needs that emotional support, it can be transferred back to the peer warm lines. When we think of someone to respond, Cindy Driggers and her colleagues are here from Benchmark Mobile Crisis Services. They're back there at the table in back corner. They're available region-wide, and we have mobile crisis services available statewide. Mobile crisis services, I have a short video that I'll play momentarily that explains what it is, but they can virtually respond anywhere, anytime to someone that needs that level of care. Melissa spoke extensively about our coordination with 911, and I'm really pleased that here in Cobb County that they do transfer calls to 988. Some counties don't have the capacity or the comfort in doing that, but we're really pleased that some of our larger counties are comfortable doing that. We've done a lot of work with the Georgia Emergency Communications Authority, which is a state authority that works closely with our public safety access points or 911 centers. But I'm really pleased that we do have that interplay here. And then we also have community provider response. The one thing you won't see in the Summit to Respond is our co-responder programs, who are here today and will be part of the panel. And the reason for that is that those groups are typically dispatched through 911 as opposed to 988. So that's one of the reasons why they're not included. One of the things that I frequently say is that fortunately there's more than enough work to go around for our mobile teams and our co-responders. And so we've intentionally kept the co-responder dispatches through our 911 centers, kept mobile crisis dispatches through 988 so that we don't have the same teams responding to the same crises. We need all the resources we can get in the community, so we don't want to duplicate them wherever possible. And then in terms of the Safe Place for Help, we have multiple crisis stabilization units and behavioral health crisis centers across the state. Cobb County has one that's located right here in Marietta. It's run through Highland Rivers and has crisis services available 24/7, 365. We also have peer wellness residence centers that are more of an early intervention for somebody in crisis, that if they're having a crisis related to a psychosocial problem and need a place to go stay, but don't need that really high level of crisis care, then that's an option for them. Excuse me. We also have substance use detox services that are embedded in all of our crisis centers that are state funded across the state. We also have several standalone centers that can provide voluntary detox services for individuals that are experiencing a substance use disorder related to opioids, alcohol, or things like Xanax. That escaped me for a moment. And then we also have inpatient beds through private providers and our state hospitals. Bless you. So let me talk a little bit about what happens when somebody calls 988. They're connected to a call taker that very quickly determines the nature of the crisis, does an assessment, attempts to de-escalate, and then determines next steps. But we also have chat and text, which we like to highlight because it's something I think that a lot of younger people are more likely to use. I have a 16-year-old, and he will text me in a heartbeat instead of calling me. He texts me from across the house, for Pete's sake. So, laughable, but it is true. So, I wanted to take a few minutes and talk to you about what people can expect when they text or chat 988. And this information is available through the 988lifeline.org website. So we have certain text capacities for specialized populations. If you need language assistance in Spanish, you text ayuda to 988, and then it will connect you to a Spanish speaking text person. And then there's some other specific groups like the LGBTQ+, and others. There's more information about that on the website. But when somebody texts and chats, they'll see a wait time message. So the wait time should be under 30 seconds. And so they'll see an estimated time available for the text chat clinician to come in. If the demand is high, there's other resources on the website that people can use. And then when the crisis comes or becomes available, they will answer the text. The person will listen to you. Again, they're going to assess what's happening and then quickly try to de-escalate and identify what needs are present. All of the conversations, whether it's through call, text, or chat, are free and confidential. So if you want to share your name, your location, other identifying information, you're free to do that, but you're not required. And that's important because of that stigma. People are still nervous about reaching out. Some of our data shows that we have really high prevalence for population in rural areas. So when you think about that, I grew up in a small town. Everybody knows everybody, right? And you don't necessarily want them knowing that it was me calling for help. So all that confidential information we think is important to reduce stigma. These are just some frequently asked questions about text and chat. So if people are depressed, they're going through a hard time, the crisis counselors are here to listen. It does not have to be a life-threatening crisis. And in fact, we encourage people to reach out before it gets to that level. It's okay. If you don't need that level of care, there are other resources that you can be linked to, outpatient services, the peer warn lines. But it's important to reach out as soon as you know that you need some type of help. When is it available? It's available 24/7, 365, nationwide. And how do you start the text? So you just text 988, and then somebody will respond. There will be a few questions that they will ask, and once you ask those, it helps to route you to the appropriate group. Are they secure and confidential? Absolutely. The technology involved is mind-blowing in terms of how many factors and different things are involved to keep people's information secure and confidential. And then again, if you need to text in your preferred language, if it's Spanish, you text IUTA to 988, and if it's something else, you just text 988 and they will help get you connected to a language line like Melissa was saying. All right, I'm going to play a quick video here to explain what Mobile Crisis Services is, and hopefully you can hear it. Okay, that's not. Thank you. If we can't hear it, give me the mic. We're very flexible.
When a person who has called or texted 988 needs someone to respond, a trained mental health professional at the Georgia Crisis and Access Line, also known as GCAL, might dispatch a mobile crisis response team to help de-escalate the crisis and assess the individual for the right level of care. Once they get the call, the mobile crisis team will reach out to the individual or the person who called on behalf of the individual in crisis. The team will first confirm the information they received and will provide an estimated time of arrival. Usually, mobile crisis teams respond to people in crisis face-to-face by traveling to their location, but they can also meet the individual using telemedicine when the person is in a safe setting, like a hospital, jail, or school, and when others are around who can keep them safe, share information, and help the person communicate if needed. Mobile crisis teams that respond on-site are comprised of 2 team members who work in concert to meet the person's immediate needs. Teams are comprised of a master's level or licensed clinician and a paraprofessional or certified peer specialist. Before they respond, mobile crisis team members receive extensive training on rapid assessment, crisis intervention, de-escalation, and how to provide person-centered and recovery-focused services. There are 2 members on each team, which ensures the safety of responders in a crisis, and it allows the team members to talk with multiple people and or conduct an assessment and de-escalate the person at the same time. Because it's important to respect the privacy of people receiving mobile crisis services and avoid further escalation, the crisis teams arrive dressed in plain clothes and in unmarked cars without lights and sirens. As a result, it usually takes them longer to respond than a first responder who is dispatched through 911. The expectation is for mobile crisis teams to respond on-site within 59 minutes. Once the team arrives on scene, mobile crisis responders immediately get into information gathering mode. They talk to the individual in crisis, as well as other people such as family members, teachers, or others who are present and who are willing to share information. These details, along with the clinician's observations, are critical in making an assessment and recommending the next steps based on the person's needs and preferences. In most cases, the crisis can be de-escalated and is referred to an outpatient appointment. Other situations might require further evaluation and treatment to ensure someone's safety and the safety of those around them. When a responder determines an individual in crisis needs further evaluation, team members will work with the person to seek treatment voluntarily because evidence shows people have better treatment outcomes when they choose to seek help on their own. Licensed clinicians only sign a 1013 or 2013 order that requires the individual to be transported to an emergency receiving facility for evaluation when the person is determined to be at imminent risk to themselves or others and will not voluntarily seek evaluation or treatment. Mobile crisis teams work hard to identify the least restrictive level of follow-up care that meets the person's needs based on their current wishes. Mobile crisis services are available statewide in Georgia and can respond 24 hours a day, 7 days a week, and 365 days of the year. They serve people almost anywhere in the community. This service is funded through DBHDD and is available to anyone in Georgia, regardless of insurance status. When a person
there's questions at the end, I'd be happy to address those. One thing I forgot to mention when I was talking about 98 calls coming in is what happens when a caller is calling from out of state, an out-of-state phone number. And thank you, Cindy, for mentioning this to me early to make sure I talk about this. So as it currently stands right now, if somebody calls in from a phone number that's from Colorado or Florida, South Carolina, those calls are routed to the call center that serves that part of the country. That was a challenge that the state or the federal system was not able to address prior to the rollout. But the good news is that we have a solution, and it is right around the corner. So the federal government, SAMHSA, and Vibrant Emotional Health, who is our federal contractor for 98, along with the FCC, have been working very closely, and the states have given a lot of feedback about how to improve that so that people still have anonymity whenever needed and desired, but there's better routing of calls. So in the fall of this year, we expect geo-routing to begin for 98 callers. Now, geo-routing means that a caller calling from a cell phone will ping a cell phone tower that's closest, and that will designate what call center serves that person. So if we've got a college student that's going to UGA, which, big fan, can't wait for football to start back up, but if they're out of state, great football player, and they go to UGA, have an out-of-state phone number, they call from that number, they'll be able to be connected to Georgia. We have a really high military population in Georgia, and just a lot of folks that move here because it's a great place to live, and don't change their cell phone numbers. And so we think this is going to be a great advance in 98, getting people routed to what they need as quickly as possible. In the meantime, all of our call centers have that local call center that would serve the person, but that's one more step in getting people connected to what they need. When the rollout occurs, it's going to occur with kind of the big three cell phone carriers, and the smaller carriers will come on later, but we anticipate that once the big three get on and everything's going well, then others will follow suit rather quickly. The beauty of this is that while 98 getting in place by 2022 was legally mandated, the cell phone companies are now doing this voluntarily because they recognize how important this service is. So that is something that we're looking forward to. We expect there might be some hiccups, so if you start to see that, let us know, reach out to your regional people, you can reach out to me, because we can communicate that to our federal partners if in fact that occurs, although crossing our fingers that there's no hiccups. All right, and I have like 1 minute left, so let me just talk about some resources. We have a website, 98ga.org. It's got all sorts of information on it. Downloadable handouts, it's got that mobile crisis video. It's got a video that First Lady Marty Kemp made for us. She's a great supporter of 98. We're very grateful for her partnership, and all sorts of other great things that you can go to. If you want to order materials from SAMHSA, there's a link to their store where you can go on and order cards, magnets, posters, bumper stickers, all that stuff for free. And then if you're a data, I don't want to say geek, but if you're a data geek like me, I love my data, there's also a portal that people can use to go see what's happening with 98. I have shared regional resources. I know that Dante McKay is here from Region 1. Dante's the regional coordinator for the Region 1 field office and leads an amazing team. So their contact information is up there, as well as contact information for Highland Rivers. I forgot to put benchmarks information up there, but they do have representatives here as well as Highland Rivers. And then if you need anything, here is my contact information. So do we have time for questions? Okay. Okay. Ma'am? slide deck, because I didn't realize it would be that hard to see. I apologize. Sure. Yes, ma'am? Okay, so the question, in case you couldn't hear, was what are our views or stances on law enforcement involvement and then any associated costs that arise based on involuntary treatment? So when it comes to 988, we do have some circumstances where an individual does not call 911, they call us at 988, and they're at very imminent risk. They are the types of things that Melissa described. In those circumstances, we will do a warm transfer to 911. Those happen to 1 to 2% in all of the calls that come into GCAL, and they get 800 calls a week. So it's not very many compared to how many come in. And our call takers are very carefully trained to determine those situations. When they are warm transferred over, we do encourage that if there's a CIT-trained officer or a co-responder to dispatch, that they are dispatched. And we have good relationships with our 911 partners. As far as the second question about any associated costs, I do want to say that calling into 988 is free. Mobile crisis services are free. They're all completely state-funded. If an individual is uninsured or underinsured and goes to one of our state-funded facilities, it's unlikely they're going to receive a bill. But if they go to a private facility, there might be insurance co-pays or things like that that are really outside of our control, because those are associated between, it's an agreement between the person and their insurance company. So did that address your question? Thank you. Ma'am? Yes, some of the LGBTQ plus individual calls or texts, and once somebody that is specifically trained, all of our clinicians are trained in diversity, but there's a group called the Trevor Project, which many of y'all may be familiar with, that has a contract to serve that population. So if they call or text, they can enter 3, and they'll be connected directly to the Trevor Project. Now the upside of that is it's people often with lived experience and that are very specifically trained for this population, but the downside of it is that they're not in Georgia. So if an individual needs a mobile crisis response or something more, they've got to connect them back through our call center to have those dispatched. The other populations other than veterans, Spanish-speaking, and LGBTQ is individuals that are deaf and hard of hearing. So if an individual needs assistance like that, they can enter 4, and then they can either do video phone or the telephone translation services. But thank you for asking that question. Okay. Yes, ma'am, in the back.
Good morning.
Certainly, and thank you for being here. Thank you for your support. We have had generous support from y'all over the years in funding these programs. So We have connections that can let us know if somebody has Medicaid. That is connected through our administrative services organization. If somebody is unfunded or uninsured, we have our community service board network that's available statewide, that we can connect that person for outpatient services or even crisis services. When it comes to private insurance, that's a bit more tricky. It's really a matter of self-report, and then we can help link people up through their insurance company to in-network providers. But I don't think our system is so sophisticated that we can say, Dawn's a provider that takes Blue Cross and Blue Shield in Augusta and get that done. I know that with House Bill 1013 a couple of years ago that was signed into law, there was some language about parity, and I'm not an expert in House Bill 13 or 1013. I'm trying not to get over my skis, but there was language about communication between the insurance commissioner and service providers and things like that. I think that is an area where we can continue to work because, in my personal opinion, I don't think it matters who your payer is or if you have no payer. I think access is very important regardless. So, Representative, I hope that answered your question. Thank you. There's one more, but we need to.
This is our last one, then we'll go to the panel, and we will have time for questions.
Okay. So you're talking about having more providers become in network with insurance companies?
Not necessarily insurance, but just being able to start. So I know you talked about on the crisis side, there are specific organizations or very entities that they can start with, but we know rural areas, most people don't exist. So where do we go to the big providers that are right in these local areas, so they can
Yes, thank you. So the question was, what are we doing for non-crisis access? And again, for the uninsured, we rely very heavily on our community service board systems throughout Georgia. Most, if not all of them, have what we call open access. So if a person needs a crisis appointment, one can be made and they can be seen rather quickly. And we do encourage our CSBs to serve people with insurance, although I think they could speak better to that about what providers or what insurance companies they go to. But they also serve people with Medicaid, so I think there's access for those groups. Although we do recognize that we're always looking to expand access wherever possible. One of the things that's helped us with that is being able to use telemedicine. It came in quite a bit during the pandemic, and we realized that it really works. In many cases, not in all cases, for people that are in rural areas that have broadband access and can benefit from services being delivered via telemedicine. So I'm going to turn it back over to our facilitators, and thank you for your time today.
So thank you so much. Caitlin is going to come and moderate the panel. So if our panelists could come forward. Thank you so much, Dawn, for being here.
How is everyone this actually an acronym that stands for Community Assistance Referral and Education Services. And our overarching goal is to address, kind of sounds negative when you say this way, but 911 local utilization. So, you know, a lot of people dial 911 not necessarily because they need emergency services, but because they don't know what else to do. And who can blame them? For years, we've never blasted dial 911 on the side of our fire trucks and our police cars. And, you know, we told the public to dial 911, and, you know, I don't know why we're surprised that they did it, but we told them to. So, but oftentimes that is not the correct resource in the county to utilize. And so my team strives to reduce that whenever that is appropriate. Most of our referrals come from responding fire crews. Sometimes we get referrals from 911 directly. Sometimes the police will send them to us. And then our number is out there in the public quite a bit now with those. They know we exist, so they'll call fire departments that way. People just don't know what to do. I want to come out there and visit with them. By reducing 911 utilization, it would also indirectly impact ER and eventually bed usage as well. So they're seeing those numbers a little bit at Wellstar. Cobb County is still growing, so it's kind of hard to gauge our metrics because every time we think we have a problem or an issue solved, another 1,000 people have been in the county and they're going to bring issues with them as well. So it feels like whack-a-mole sometimes, but we do feel like we're doing good and we have a lot of success stories that we're really proud of. A lot of times the reason people call 911 is they need us very simple resources. So a lot of times our issues are solved quite easily. We keep the cache of equipment, our mobility equipment, our hoarding units, wheelchairs, walkers, rollators. So there's a lot of stuff mobility and task tape. We'll go out there and try to solve a problem where it exists there in the house. We found that a lot of people don't know how to get their medications. They have transportation issues. They have financial issues. And oftentimes we're able to help with that with some partnerships we've built with the various pharmacies. Don mentioned telehealth earlier. I've had a lot of good things to say about telehealth. We utilize it a lot in the CARES program. And we've just seen a lot of success with that as well. And that telehealth is often able with their navigators to help with transportation issues. Food insecurity is still a problem here in Cobb County, I'm sorry to say. We have an incredible partnership with the Salvation Army. They're very good to us. They love the CARES team for what we do. And they I can say that good things about them as well as Salvation Army. So we're able to help people with their food insecurity issues. Another program that we do that kind of ties into mental health is substance abuse. A lot of times those go hand in hand. So here in Cobb County, we circle back the next week after every Narcan administration for potential overdose and go revisit those folks and just make sure they know about the zone. They're represented back there today. And the resources are available to them. We leave Narcan administration gets behind. And also leave fentanyl test strips behind to try to, just basically let them know what's in the county and if they're going to use them, let's do it safely. And then we also deal with our elderly population in cognitive decline. You might have heard we just started a program called Project Lifesaver, which helps us find our known, sometimes folks like to leave the house and forget to mention anybody to take them to leave the house. So we got Project Lifesaver on board, and that's right for the CARES Commission as well to help us find those folks. So we have many partnerships throughout the community. Lowe's Home Improvement is they help us with supplies for building ramps, things like that. Sometimes we can get churches to help out. FODAC, we're partnering closely with SafePath, Right Side, Salvation Army, as I mentioned, SEMA as well. And then we have the LPCs that we have with Sheriff for PAT team and case managers from Highland Rivers. So we can go out and address the mental health issues. I was going to say the difference between the CARES team and the PAT team is, you think about it like this, the CARES teams mostly deal with chronic, ongoing issues within the community that 911 is having to deal with, where the PAT team generally deals with something that has to be handled right this second. That's the best idea for us. That's the basic general rule. Those overlap quite a bit, so we're all not together in the same office, not on the street, to work together for our case loads every day.
Hey, good morning, everybody. I'm Jacob King with the Cobb County Police Department. I'm assigned to the PATH team. So An overview PAT team stands for the Partnership for Assistance, Treatment, and Health. And what we are is we are a mental health crisis response and intervention team. We utilize what is known as the co-response method, or model, I should say. And this is nothing more than a licensed mental health professional, usually an LPC or an LCSW paired with a law enforcement officer. And our primary focus is, again, on mental health. So what we're looking at doing, we have a bunch of goals, but among those primary goals is we're trying to reduce incarceration. So we're trying to reduce people being arrested because they're having a mental health crisis and they violate some sort of public ordinance, right? We're looking to reduce use of force. We are looking to divert these people away from the emergency room. If you haven't been to an emergency room lately, they're extremely overcrowded and overburdened. So we're trying to put people that don't need medical help into appropriate care. And we're trying to also keep them out of ambulances because there's always a shortage of ambulances. We need them available to deal with the issues that they are intended for. So that's the crisis portion of it. That's where there's typically a 911 call. Somebody is in crisis. They may be suicidal. They may be threatening family, damaging property. It could be any one of a number of things. Pretty much any call that comes into 911 could potentially be related to mental health. So we go out, we assess the situation, we work towards de-escalation, and if in those instances where there's no other solution, involuntary hospitalization is necessary, our clinicians can sign that order and we can enforce that order and transport that individual. Now, I will say this, we are not replacing incarceration with hospitalization. We are only utilizing that as an absolute last resort. And I think we're running, last time I checked our numbers, about 25% of the calls that we respond to result in hospitalization. The other 75%, we're able to de-escalate the situation, mediate the immediate dispute, whatever it is, and then start a process where we're going to go back later on and follow up with that individual on a monthly basis. And that's where we probably spend the bulk of our time, is meeting with those individuals, talking with them, trying to encourage them to speak to a therapist, speak to a counselor, take medication, whatever is necessary for them to deal with their particular concerns. That's what we're trying to encourage them. We're also trying to destigmatize the relationship between law enforcement and members of the community that have mental health problems, right? Because we want to make them understand that not every interaction with a law enforcement officer has to result in jail or hospital, right? So if we go back out once a month and we have a conversation with them and it's pleasant, then there's some other viewpoint of law enforcement. And then maybe the next time, if they're in crisis, they remember that we don't have to take them to a hospital. We don't have to take them to jail. We avoid the use of force, if at all possible, by humanizing us and making them recognize that we're not their enemy, we are legitimately there to help. The co-response model, or co-responder model, is honestly invaluable to us. I don't think the citizens of Cobb County will ever realize how much service the two LPCs that work for us have provided to them. They're absolutely invaluable. They allow us to handle these crisis calls, especially when hospitalization is necessary, in a time frame that's unbelievably fast. And it's that quick handling time that prevents usually that build up to a violent encounter. The longer we're on the scene and the longer we're dealing with someone that's in crisis, the more likely they are to amp up, escalate into a violent encounter. And that being able to make that decision not only accurately, ethically, but quickly is what gives us a huge advantage and allows us to perform things, to perform phenomenally well in the field. So that's an overview of what the PAP team does. Again, we are primarily focused on mental health crisis and intervention.
Thank you guys. That was very insightful and probably answered some of the questions I already had. But kind of directing to 911 with Daniel and with Jamie, I wanted to ask, with Cobb Cares and Cobb Path, right, we're very unique in Cobb County and we have these robust services. So what makes that really different from the other counties that we're working with? How do we operate together with 911, working with
resources, the only option is the officers, right? Like Officer King saying, you send a police officer out, they are treated de-escalation, but they're treated like a base level, not in a way that a unit that's on TAP or CIT trained is. So it gives us a wider variety of people that we can send out to service the community. It also takes the burden off of us as 911. It allows us to better serve with handling emergency calls, because whereas previously someone may be tied up on a call with someone experiencing a mental health crisis until police responders get there to help them, now we have these other services that are available to come out and kind of take that. And like Keith was saying, there's also that early intervention of when they know we have a person who's going to be in a repeat needs, where they're going to need repeated contact from us, they can kind of intervene on that end. So we're not taking the burden of, hey, there's repeated 911 calls from that person. They're proactively reaching out to that person and kind of keeping tabs on them. So it takes a huge burden off of us compared to like a place that has none of these resources.
Yeah, and that really, I think, goes to that question that a lot of us have and are posing of, you know, what is that thing that happens afterwards? What is that follow-up? Once that call is made, how do I know that that person is getting the care we need? And then even when the call is done, right? How do we know there's getting follow-up? So maybe if, you know, each of you could speak to how that follow-up looks within each of yours, you know, with those monthly visits, following up, leaving Narcan, providing those supports. But what does that look like, and do you receive any pushback?
I mean, this will be more for them from the 911 perspective once we take a call. A lot of times we don't even know what the outcome of it was because we're moving on to the next thing that happened. But we do kind of keep in touch with peers in the path of people that we do know in the area that have those things that we know, hey, you know, they've just been out with her last week. Let's make sure we're getting them in touch because they've got that relationship with her. So next time they can kind of come out and help with that. But it's probably more your dealio.
I think I understand the question. So we carry a caseload, at least in the CARES division, of about 50 to 60 a month that is handled by 6 full-time community paramedics, and then we also rely on some part-time guys that come in and help us out as well. So like right now, there are 3 CARES teams out in the community right now. They have their assignments that everybody was clear on after our team shift up this morning, and they're also listening out for these crisis calls as they come in. So it's just a matter of case management. Each one is different, but before we ever leave a case that we know is going to be open, we just go ahead and schedule that next interaction for whatever we think, a week, 2 weeks, you know, next month, whatever they want, until people think that they're good and follow up with on their own. Going back to the telehealth, sometimes those navigators are able to take that burden off of us, and if they're able to get them going to the representative's question earlier, find them proper insurance and what the best we can provide for them, then they'll go ahead and take those cases on from there and start making sure that they make their appointments and whatnot. And you know, they don't hesitate to call us back either if we just think a case is closed and it turns out it's not, so we have a transportation issue or whatever it may be. And you know, ask us if we can come back out and help them. So just because a case is quote unquote closed, or just because we think that they're in a good place, they know that they can reach out and at any time instead of our 911 to the CARES team directly, we'll go back and drop back in front if we have to.
So as far as reception from the individuals that we interact with, it's important to understand that these people are not on probation. They are not mandated to talk to us. They're not required to answer the door or call us or engage with us in any way, shape, form, or fashion. The vast majority of the time, they're all too happy to talk to us. We deal with a lot of individuals that have deal with delusional thoughts. This makes them typically unpleasant to talk to, even for family and friends. So in some cases, we've got individuals where if we didn't go out and see them, they might not have a pleasant conversation with another human being that long. So it's been very well received. I think our caseload right now is about 45. It's been as high as 90, and it just kind of ebbs and flows as people move into the county and move out. We do have them to speak. One of the things that does is that keeps them from taking up 911 by calling 911 to tell them about their experiences and their thoughts, right? They can divert those calls to us. They can tell us that when we're out there talking to them. So in general, again, the commitment to those cases is we'll continue to follow up and meet with those individuals till they tell us they don't want to. They move out of the county or they pass away. We're committed to helping those individuals long term and maintain that relationship. Yes. So typically we would handle that basically the same way as if we had to arrest an adult. We'd be looking to find a competent family member to come out and turn the children over to for the safety for that time frame that they're going to be unavailable. If that is not possible, then we do have a crimes against children unit that we typically reach out to. They coordinate with resources like Child Protective Service, et cetera, to facilitate placement. Probably not in the phone call. That's going to be more of we've pretty much resolved all the other issues. A decision's been made. That's more of kind of cleaning up the scene before we meet. So typically what we're going to look at is we're going to ask the individual, hey, who do you want your children to go to? And then facilitate that. And that may mean sitting on scene, letting that other person come over and take us to the children or transport them if need be.
John wants to respond to it. And if we could hold questions to the end, and we've got note cards that we can write down the questions. We've got some questions to get through, but we'll have time at the very end for some audience Q&A.
Thank you. So I do want to address a couple of things with follow-up. First thing as it pertains to our co-responder programs, I think one of the real benefits is that the clinicians that work with our co-responders are embedded within the local community service board. So they work for Highland Rivers here in Cobb County, which means they have access to individuals' records, right? And so if the individual is engaged already with Highland Rivers, they can look to see maybe they missed a shot, have they missed their last appointment, and that will really help to identify what's the next step. If y'all are getting multiple calls on the same individual, maybe that person needs to be referred to a higher level of care. And Highland Rivers, if you're back there and I'm saying something that's wrong, just tell me I'm wrong and shut out the answer. But it's a really good partnership, not just to build relationships between police and the CSB, but also for that continuity of care for the individual. And then as we think about services for 988, all of our crisis service providers, whether it's the call center, when they're transferred to 911, there are follow-up calls that are made for that, or if our mobile crisis teams or our crisis centers ultimately end up serving a person, there's follow-up required with that as well, just to make sure that they are connected, and that person's not just left. They're not in crisis anymore, but just because you're not in crisis doesn't mean you're perfectly fine. You probably need some support. So just wanted to address that before we move on.
I appreciate that. And with that too, and being in a crisis and having these moments too, it's very unique to us as individuals, our own perception. And so when thinking about, when to call 911, when to call 988, if we're having these crisis moments, is there a crisis that may be too big or too small to call 911 versus 988? And what happens if we call the wrong one? Say I call 988, but that person may become a danger and I'm not connected to 911 already.
I'm glad you asked that question because I was going to address that, but I forgot. So glad you asked it. Because Cobb County has such great interplay between 988 and 911, I would say call whichever one you think it is, whichever one you think is needed, and there are professionals on the phone that will be able to quickly determine if you call 988, does it need to go to 911, and vice versa. experiencing crises, it's a lot. I mean, it's terrifying, even if it's not a mental health crisis. And so, when in doubt, just call, and call the one that you know, the one that comes to mind first, and just let the professionals figure it out from there. So, I hope that addressed your question.
Yeah, if anyone else would like to take a stab at that too.
Yeah, I mean, the way that I typically explain it to our recruits when they're coming through the program is, to me, it's like the urgent care versus emergency room, right? 911's here for emergency care. So if you have someone that has actually attempted suicide, completed suicide, a situation where that person's in need of urgent medical care, absolutely, that needs to come to 911 because that's a medical issue at that point, right? But a situation where someone's having suicidal ideations, or maybe they're going through just another kind of crisis, it's not necessarily suicide or mental, like they have just another crisis going on. 988 is great for that. Like Dawn has said, they have a team that's set up specifically to talk to those people long term, to talk them through it. So that's at least how we kind of make the differentiation. But just like the ER, if you show up, we're going to tell you no, right? Same thing with 911. If you call 911 instead of 988, we're still going to take care of you. We may transfer you out to another service if that's what you really need. But 911 in 2024 isn't just like, hey, I'm calling for an ambulance. We do a lot now because, like they were saying earlier, it's the most accessible number to citizens, right? Everyone knows 911. If they don't know who else to call, they're going to call here. So, worst case, they call 911 and we'll still take care of them and send them 988 if they need it. So.
Yeah, thank you. And I think that's so important to know too, because when we're so used to 911, I think we're most people, especially us in this space, we know about 988, but some of the clients we serve may not know, and we can really share and pass along this information. But it's good to know too that there is this kind of full circle support around there where we have the directions. So even if they don't know who to call exactly, the trained professionals know how to really direct that call to provide the support that is needed in that moment. And so kind of thinking through maybe some real life scenarios that we may be involved in, may come across one day. So let's say I have a parent or a client who may be bipolar and they're in the middle of a manic episode and I am lost and don't know what to do, maybe as a child, maybe as the provider. So where would you really start in that instance? And maybe if Matthew wants to take a stab at this one, or Danny, I know we haven't heard from Danny either, so what kind of is there?
Help is there?
I guess, where do we really start? So if it's a mental health crisis, and as a supporter, as maybe a parent, child caregiver.
Well, the example of someone that's coming and maybe distressing, but not being violent, they're bizarre, maybe they've been away for 4 days and they decide they want to paint the living room long or something along those lines. Yeah, that 988 would be a completely appropriate first step to let them know, hey, my loved one, my patient, my father or my dad is having these kind of issues. Who do I get in touch with? Who do I talk to about getting some help? That would be a completely appropriate thing to start off with. 988, they can get an idea of what the situation is. They'll start taking all your information. If it's need be, they can send a local crisis team out, or they can start helping you set up appointments with like a local CSB, or a person happens to have a certain particular
someone called or having a mini episode, we would most likely one of our trained professionals will use one of the protocols we've been trained on to field the call. The person will address with caller safety, make sure the caller is in a safe place, and can basically, if they are in some sort of crisis, we try to divert them to a safer environment where it's a bit more calm and secure. And the next thing we address with the officer safety, making sure that the officers, whether they do dispatch out there, whether they be EMS or police officers, when they arrive on the scene, that they're not going to put themselves in danger based off what the caller is experiencing. And then we would say on the phone to make sure that the scene stays out there until the officer
And to Matthew's point, brought up something of like, if we're just experiencing a strange or that may a crisis, maybe what is that we do if we're not really sure? Are they, maybe having an overdose? Are they maybe having a mental health issue? Are they having a physical health issue? Right? What are those things we do when we're involved with a stranger, knowing safety of ourselves and safety of the people around us? But let's say that we are working with students. Maybe it's a moment where it's not an immediate crisis where I know I need to call 911 right now, or I know I need to call 988 right now. But let's say I'm working with a student maybe who is showing signs of suicidality, kind of the withdrawal, the typical signs we might see. How do we approach sharing 988, sharing these resources, sharing information about how CARES and PATH and what is available to them in a sensitive way where we can do it appropriately, I guess?
So I think the first step when you're dealing with anybody that's having suicidal thoughts, you've got to be very direct. Suicide is not a comfortable conversation for most people. Thank God, right? Because that means you all cling to life and you want to live. When you're dealing with someone that is legitimately suicidal, they're already in a very bad place. If you appear to be uncomfortable talking to them, you're using euphemisms. Are you thinking about hurting yourself instead of being direct and asking very direct questions? Are you thinking about killing yourself? Are you thinking about committing suicide? Right? You're going to come off as being uncomfortable. And if you're uncomfortable, they're going to see it. They are not going to feel comfortable telling you anything. Right? So that's the first thing that you've got to understand. You've got to be comfortable talking about it. If that's not you, find somebody that is. And then you've got to have the ability to kind of sense out what is an immediate risk and what is somebody's having a bad day and the thought of suicide came to their mind, right? We probably respond to hundreds of suicide calls every year. There's very few people that typically follow through with it. And the best way to share that stuff is to ask them what's going on, right? Use open-ended questions. And once you've got a good sense of why they're in that space or why they're in that place in their life, and you've shown them, hey, that you're engaged and you're concerned, that's when you start bringing in and talking about resources. That's when you mention 988, right? If you just hear somebody say, hey man, I'm having a bad day, I'm thinking about killing myself, and you throw them a pamphlet, when you throw them a card, when you throw them a website, what you're sending, the message you're sending to them is, yeah, I'm concerned, but not concerned enough to get involved, not concerned enough to have a conversation. The minute that comes out, you need to be prepared that, hey, everything else stops, right? Everything else is secondary. I have to talk to this person. I have to talk to them now and figure out how much risk they are to themselves, right? And most of the time, that conversation is typically going to be enough to mitigate the immediate risk. And once you feel confident that they're not going to actively follow through, that's when you start the referral process. There's cards. GCAL will give out cards to organizations by the whole truckload. So if you want to request them for free, you can get truckloads of the GCAL cards. You can hang on to those. You can pass them out to your churches, your school groups, whatever, right? You can provide them, you can get those resources. That's the easy part. The hard part is learning how to talk to those individuals.
So I absolutely agree with everything that was just said. And want to say, though, that someone can call GCAL at 988 on behalf of someone else. So it doesn't have to be handing a person a card. I agree with what you said, that sometimes that might seem really impersonal. But you can call, you can three-way them in. You can do all sorts of different things, or have that person in the room with you while you're calling on their behalf. The other thing I want to say for schools, two things actually. The first is that we have a very robust APEX program here in Georgia. So the Georgia APEX program has been in existence for 8, 10 years. Dante's nodding. He used to oversee the program at the state level. And it's where our community service boards have therapists and paraprofessionals embedded literally in schools. So if you're in an APEX school, teachers know who those answers are. They can reach out. The counselors can support the teachers, the students, and whatnot. And then the other piece is that if that's not the case, they can either call the Georgia Crisis Access Line or call 988. And then one thing that I'm really excited about, this is literally like, I'm working on this for the past 2 weeks, is we're starting to partner with the Georgia Department of Education around 988. Because a lot of people have heard of it, but a lot of the teachers and school staff are like, we don't know what it is or when to use it. So we're in the very baby steps of moving forward in that way, so that we can do some education about what to do and when to use it and how to be knowledgeable. We undertook a program last year with the University System of Georgia that was much the same thing. So if you go to a USG school, you should see a 988 sticker on the mirrors. Can't wait to go to a Georgia campus year and see it. It'll make me happy. But we're also doing some education for their staff that are recorded on-demand webinars, so that if somebody can't make a meeting, they have access to what is 988 and how to encourage people to use it.
Thank you. So much great information. You want to have one last thing? Well, yeah, to round it out, we just want to go through and see if each of you have one thing you want the audience to take away from today. Obviously, we could spend, again, all day on this, but what is one thing from this meeting today you want people to take from? Go down the line.
So my big takeaway is kind of a two-part takeaway. So, is first of all, please encourage people and you yourself not to wait till it becomes a crisis to reach out. And when in doubt, reach out.
Yeah, it's very similar to what she said. No one is there if you need help, if you have requirements with community. We will direct you to the GCAL. So again, don't be afraid to reach out for early intervention. You can reach your community, or people who see that now, call them when you see the company.
I feel like super unoriginal, but samesies. Just remember, like, don't be afraid to make the call, whether it's for yourself or somebody else, whether it's 911 or 988. Yeah, we're different groups and stuff, but this is all one big cooperative effort, right? We communicate with PATH and CARES, communicate with 988, Highland Rivers, all these groups within the county. So don't be scared to call. Even if you don't know and you call on 911, we'll make sure you get to who you need to get to. So don't have that anxiety and like, am I calling the right person? The important thing is you're calling.
I just want to say, all of you that live in Cobb County should know more about the resources and the available things that the community offers, from Cobb Collaborative to the Zone area to some of these other places I mentioned in the introduction earlier. We're very fortunate from our county leaders, top down, to have a lot of support. Our fire department is very well, funded, is very well managed, and that's why we're able to have a program like Cobb Cares and put all these resources together to get people to the right places. But I've lived and worked in a couple other places, and I can honestly say that you guys that live in Cobb are in a good spot where the community supports the citizenry.
I have to agree with that, that there are resources out there. input. We're not overflowing in resources, of course. There's always limitations, but there are stuff available. If you look hard enough, you can find some kind of assistance somewhere in Cobb County that we can get help to.
So on just a slightly different track, if you have to call 988 or 911 and you're in crisis or you have a friend or a loved one in crisis, the more information you can give us, the more effective our response can be. And if you can avoid exaggeration, the more appropriate our response can be. I cannot count the number of times I go into a scene and I'm expecting to find the Incredible Hulk tearing people in half and throwing cars down the road, and I get there and it's nothing more than a verbal argument, right? So if you have to call, please just tell us precisely what's going on. Be very as descriptive as you can, and don't embellish the story. Right? It makes it easier for us to figure out what needs to be done. If you call, we're coming. You don't need to exaggerate to get us to come.
Well, thank you all so much. I know we probably have a lot of questions in the audience, and unfortunately time will not permit. So if you could write down all of the questions that you do have, and we will make sure to follow up and get those answered to the best of our ability so we can be a more informed community and support one another. So